I have a question for Professor Kalajian. We all agree that interferon is not effective in patients who have significant myelofibrosis and osteosclerosis. And if you are studying patients with intermediate 2 and high-risk disease, don't those patients have a lot of myelofibrosis on the bone marrow biopsy? And why would you anticipate that the combination of interferon and Rux would be effective
Indeed,
rather than Rux alone?
Yeah, we don't know. We know that ruxolitinib alone may, in some selected patients, reverse the fibrosis, but it takes a very long time.
Right.
All the published data until now at least require 4 to 5 years of treatment, and Serge maybe has the longest experience because he started the treatment in phase 1-2 studies with ruxolitinib. So it takes a long time. On the other hand, as you said, interferon seems less effective once you have a grade 3 fibrosis. So I hope we'll see. All of our patients until now have grade 2 or 3 fibrosis, of course, and we will have a set of 40 patients with 2 sequential biopsies, and we'll see if we can, in some of them, have some results or not.
This is a very good question, but you see, in myelofibrosis, with ruxolitinib, you have a good control of signs and symptoms of the disease. For me, primary reason to add interferon is to have biological effect on the disease rather than clinical benefit. I do not really expect that interferon would be able, that we would be able to add significant dose on interferon because it will compromise the use of ruxolitinib. On the other hand, it may have a much better effect on the malignant clone. You know that with ruxolitinib there is an average about 20% decrease in injectable burden, but it's not much. With interferon, at least in PV, 20% of the patients have no injectable burden anymore, which would be major molecular remission. If we can do something like this, major molecular remission with interferon in myelofibrosis, then we combine the clinical benefit of ruxolitinib with biological effect of interferon. So this is a very interesting study, although I would hope that there would be a randomized study, that you see whether interferon can add something where you would add patients, you have a ruxolitinib with or without interferon, to have a parallel groups so you can really dissect this in much better way. Okay, we have a few questions. Please be don't shy. We have a time to answer any question across the spectrum of diseases from PV to myelofibrosis to hepatitis. And there is also ability to send questions through the electronic gadgets here. So one question here. For teenage patients, and Dr. Silva, this might be for you. For teenage patients with multiple hemoglobin test results approaching upper limit of normal, is it necessary to conduct a JAK2 mutation test, biopsy of the bone marrow, or anything else? We are talking about the teenage patients with multiple high normal or slightly above normal, I guess, also hemoglobin levels. What would you do?
So the first thing I would do is take a careful history because marijuana and other social drugs
Marijuana?
Marijuana.
Okay.
Opioids cause restriction in plasma volume. And we've had several teenagers who have been referred for high blood counts. And I refer to blood counts because hemoglobin, I mean, you define polycythemia as an increase in red cells, not as an increase in hemoglobin. So the first thing I would do is take a careful history, make sure the person doesn't smoke, because again, cigarettes reduce plasma volume. Also, if they're drinking, because alcohol reduces plasma volume, and take a history about social drugs. And I would make sure that, again, to see that the person is adequately hydrated, particularly after sports, and because we've had people who have come in with high red counts after playing varsity football in the United States, and it was just a simple question of dehydration. So there are many causes for so-called increase in blood counts, we actually wrote a paper on this. And you have to make sure that the count is done at the same time during the day, because there's fluctuations in the day in the blood counts. And women who menstruate, there's fluctuations in the blood count. In there are seasonal variations, et cetera. So I would make sure that the count is done accurately with a good history before I do anything. Certainly, a JAK2 is easy to get, but I wouldn't do a bone marrow biopsy until there's demonstrated evidence of a reason for it.
That was very good. So we have another question here, and this is related to ability of interferon to suppress most but not all types of mutations in patients with the polycythemia vera. And one that you, Dr. Kelajian, pointed out was a TET2 mutation in some studies did not really get suppressed, while others do, and particularly JAK2 does. Is there a biological explanation? What do you think about it?
Well, that's a very, very good and difficult question, I think, to answer. What we have observed with our colleagues from William Venschenker's lab in patients treated with interferon is that the ones with the highest JAK2 activation were the most likely to respond better in terms of molecular response. It seems that response to interferon is more marked in patients with a high activation of JAK2. For example, patients with homozygous mutation responded faster than those with heterozygous mutation. So it seems that activation of the cells is part of the response to interferon. And we know that TET2 mutation alone, if there's nothing else, doesn't induce a proliferative advantage on these cells. They don't proliferate more. They're not more active than normal cells. This provides a kind of fertile background for the acquisition of other mutations, but TET2 alone doesn't seem to be a very active mutation in terms of cell biology. Right. I don't know if Robert maybe has some other ideas about that. Maybe I can give him the microphone. Or
well, your explanation is perfectly plausible. I think that there are some patients where the TET2 is acquired before the JAK, and it means that there is a stem cell pool which is carrying only a single TET2 mutation, and that is very unlikely to be responding because it looks like the interferon effect is specific for JAK V617F. So perhaps you selectively deplete the double positives much faster, and all those patients where TET2 is after JAK, they basically just piggyback on the depletion that is rather selective for the JAK2. I think that's probably the most likely explanation.
So maybe one theoretical concern with this observation is that you eradicate the most proliferative clone, but you leave on the background still a clone that may acquire other malignancies and maybe increase the risk of transformation on longer term to MDS, for example. They may acquire other mutation that will switch to myelodysplastic syndrome, but we didn't see that in any of our patients treated with interferon to date.
Same with us. We don't see any significant prognostic significance to patients who have TET plus JAK.
So we...
the US data and the French data is a true concord.
So the next question is related to Dr. Silva's presentation about the ability to interferon to do much more than just to control the blood cell count. And the question is strictly directly to, can interferon treatment stop ET or PV from progressing? Do you have evidence, and you have treated by far the most patients with interferon for the longest period of time, are you convinced enough that it can actually stop progression from ET or PV to myelofibrosis?
Oh, I'm absolutely convinced. And I think that the observation that I cited with phlebotomy stimulating the bone marrow, when you think of what phlebotomy does, it activates not only the hematopoietic stem cell to manufacture more red cells, but platelets and white cells, and all the inflammatory cytokines will result the interaction with the endothelium and the hematopoietic stem cells. So I think Dr. Najin And the French school in 1990 who first pointed this out were absolutely correct, although there was an observational conclusion as well. There's never been a controlled trial, but we are reviewing now our data bank of patients treated with interferon, and we certainly don't see the progression that we do see. We don't see the progression with interferon patients that we anticipate you see with phlebotomy-only patients. And Najin and his group were the first to point out that myelofibrosis begins to occur about 8 to 10 years after the diagnosis. And if you look at phlebotomy-treated only patients, which we have encountered many of them, they develop splenomegaly at about 7 to 8 to 9 years after the diagnosis, and you do a bone marrow and you see lots of fibrosis. Those patients, incidentally, should be treated with interferon because you can reverse the disease, although I agree again with Dr. Kalajian that if you start treating later, your results are not as good as treating early. But some of those patients have been referred for bone marrow transplantation because someone saw the fibrosis and thought this was a very bad prognostic sign, and those patients should never be referred for transplant until they have an adequate trial of interferon plus Lux or interferon alone or Rux or whatever.
So this brings us to the next question, actually. You mentioned interferon and ruxolitinib, and Dr. Kilajian, your ongoing study appears to be interesting to the audience. The question is, will the combination therapy of ropeg interferon and JAK inhibitor in myeloproliferative neoplasm would that cause too much of myelosuppression?
Very good comment indeed. What we observed in the trial until now is that, yes, after a few months, not at the beginning, but after 3 to 4 months, most of patients experience a clear decrease in erythropoiesis and a decrease in hemoglobin. And we often had to reduce the doses after 6 months of the combination, mostly to avoid anemia. For the platelets, hopefully it doesn't seem to be very marked. We have the effect of ruxolitinib that is quite well known. You see a decrease by 20–30% of baseline platelet count when you start the treatment, but further addition of interferon doesn't seem to increase the rate of thrombocytopenia. But for anemia, yes, it's clear.
Now, we have a question about the difference between the ropeg interferon and regular PEG interferon. And the difference is basically in chemistry and then what comes out of the differences in chemistry. We have, with the ropeg interferon isoform, one isoform is pretty safe and unique. And with PEG interferon, there are different preparations or different isoforms that come up in the actually delivery to a patient. So that has influence on the toxicity rate and how is this metabolized in the patient. Therefore, PEG interferon is usually given weekly, and ropeg interferon can be given every 2 weeks. Once you give it less often, you have less toxicity. You have less toxicity, you have better efficacy. And it all goes from the basic chemistry and the design of the medication. So that's why ropeg interferon has its advantages in a clinic just based on how it is made. Now, let's go on to another...
Yeah, I think Pegasus has 10 or 11 isoforms, and ropeg has only one, the proline. So presumably that's why it's less toxic.
So we have a question about what level of hemoglobin should be there in a place for one to get therapy. You were telling us, Dr. Silver, that 45...
No.
Tell us, what would you do in clinical practice in treating patients with PV? What's your guideline?
So we should really forget about hemoglobin because it was the question about what was the hemoglobin level, because we never follow the hemoglobin.
That's right.
Can you read it for me?
It says, to PV patients, what level of hemoglobin should start therapy?
Okay.
And what level should you stop therapy? Normal, basal, or a little bit higher than normal?
Okay.
So what's your general approach, your own?
So we must realize that the term masked polycythemia is a totally erroneous conception, because polycythemia, as defined by William Osler, is a disease of too many red blood cells. Polycythemia vera is a true increase in the number of red blood cells. The viscosity issues that occur in polycythemia vera have nothing to do with hemoglobin. It has to do with the number of red blood cells. Now, this is a very important point. I want everyone to listen carefully, because in iron deficiency anemia, the limiting factor is the amount of iron, so that as the red blood cell count falls, the hemoglobin falls. In polycythemia vera, because it is a malignancy, even though the patient becomes iron deficiency, red blood cells continue to proliferate because of JAK2, so that you end up with patients who are very, very iron deficient, who have very small red blood cells. And everybody forgets that the hematocrit is a derived value nowadays, because they don't measure hematocrits anymore. It's derived from measuring the red blood cell count times the MCV equals the hematocrit. So as the cells get smaller, the red blood count continues to rise. It's hard to describe this orally, but that equals the red count times the MCV equals the hematocrit. So you may get relatively normal levels of hematocrit even when the red blood cell count is very high. So under no circumstances should you look at the hemoglobin levels, because these patients are iron deficient to begin with, and they become more iron deficient as they get phlebotomized. Hemoglobins are valueless. Next valueless determination is the hematocrit, because that is affected by the size of the red blood cell. So you really should look at the red blood cell count. And the normal red blood cell count is 5 million in a man and about 4.5 million in a woman. If there's anything that I hope people will take home, is that concept of the red blood cells, not the hemoglobin and not the hematocrit. Now, if the hematocrit is used early in the course of the disease, before the patient is terribly iron deficient, that is essentially close to the normal value. So we shoot for about 45% in a man and 42% in a woman. Never use the hemoglobin, because that's a totally unreliable test in patients with polycythemia vera. And the reason we use those target levels is because that's when the viscosity of the blood, as determined by the red blood cell count, approaches normal. And that's why, if you're meticulous with keeping those levels down, the red blood cell count down, that in fact you will avoid thromboses. The interferon will merely make maybe the red cells less sticky, or the endothelium less hyperactive and the platelets less hyperactive, but it's the red blood cells that cause thromboses, not the hemoglobin. And you can distort iron deficient red blood cells. They behave just the same as normocytic cells from the standpoint of viscosity. Those studies have been done many times over the course of the years in polycythemia and other diseases like thalassemia, and it's the number of red blood cells that count, not the hemoglobin, that determine viscosity.
So we may now switch to more aggressive treatment. There's a question about stem cell transplantation, so I think, Serge, maybe you can be the one to answer this question. Can stem cell transplantation be first choice for PMF?
So the answer is yes. If the patient has, well, but there is a disclaimer here. So the bone marrow transplant is the first choice if the perceived survival of that patient based on a prognostic scoring system that you use is less than 5 years. These are labeled usually as intermediate 2 or high risk by different prognostic scoring systems. There are a number of them. I don't have a suggestion which one to use, because there are a combination of different factors in different prognostic scoring system, and depends what you have at your disposal. But if the perceived survival is less than 5 years, then yes, that would justify referring patients to the transplant. Now, the guidelines also say that if that patient has a very big spleen or liver that causes a lot of symptoms and the patient is losing weight and has a bad quality of life, it is prudent to improve the body composition of the patients, reduce the spleen and liver as much as possible with the 2 or 3 months of a JAK inhibitor to improve their chances of going through the transplant, because it has been shown by 3 studies so far that the outcome of the patients after transplant is much better if they come into the transplant in the best possible physical shape on a JAK inhibitor.
Okay, may I ask a question to Dr. Chen? I think because we discussed a lot about hematology, but I was interested to see in your presentation you showed nicely GWAS analysis that could allow to find some genetic background leading to resistance to interferon in hepatitis treatment. Do you think we can find the same kind of resistance for hematological response? And IL-28, for example, is probably not relevant for hematological response. Yes, what is your opinion?
Yeah, I think it is a very logical approach. You see that the interferon for the hepatitis patient is really depend on the IL-28B genotyping. But interestingly, for the hepatitis B, this genotyping is not important. But however, I'm interested to see in the MPN, especially after some patients are probably responded good to the interferon, but some are not. Maybe we can when we accumulate enough of the patient, maybe we can try to do the GWAS to identify any genetic polymorphism in the bone marrow, especially relevant in the bone marrow, to see there's any new finding. Okay.
Okay, maybe.
So, Dr. Kalajian, you've been very interested in interferon resistance. Where do we stand with antibodies and interferon now? And I know Dr. Hasselbach has tried to develop a methodology for that. Is that practical? We don't do that. So.
We don't either. And in fact, I've never seen a real hematological resistance to interferon in my patients. They all responded, at least in PV and ET. Myelofibrosis is more difficult to evaluate, but I never really had a hematological resistance, only maybe 1 or 2 patients. What we can see in contrast is molecular resistance, patients who achieve complete hematological response, but still don't see a decrease in their allele burden. So this is maybe different, and maybe in these patients we can find some markers to detect these patients.
So wasn't interleukin 28?
I don't think so, because IL-28 is purely a path for virus eradication, not for hematology, but you never know.
Because this gene is only expressed in the liver. But Dr. Silva just mentioned that antibody against the interferon. Actually, the Pharma Essential already did the study. They are about 10 or 20% develop the antibody, but they are not neutralizing. So you see, you can detect the antibody, but they don't neutralizing the interferon.
Okay. Well, another question about the genetic testing. It says the JAK2, MPL, and calreticulin testing, consistency between peripheral blood test, bone marrow test, and other gene tests. Now, there has been several reports of a comparison between the bone marrow and the blood tests, and they're all saying that it's about the same in all aspects, on all types of the mutations. We and Dr. Jason Gottlieb in California have published also 2 papers on the comparison between the peripheral blood and saliva. One was published in Blood, and the other in leukemia research, saying that it seems that even comparing the saliva and peripheral blood, it's about the same. But that is something to consider if you cannot test on blood. I would not do it regularly. So the answer here is straightforward. Yes, blood can be used instead of the bone marrow. And let's move on to some of others.
I have maybe one question for you. For PV treatment, which is more important, to control hematocrit or molecular response in your experience?
So the question is about what's the endpoint of the therapy with interferon. The first and immediate reason to treat is to control thromboembolic risk. And that is the control of the blood cell count. So hematological response is the priority. Only after that, and as of yet not in everyday clinical practice, is to look at the molecular response and possibly bone marrow response. These are parts of the clinical studies, not in everyday practice that I would encourage for routine use or for routine testing or for decision making to look at the molecular response or the bone marrow response as the primary goal. These are correlative studies that are useful, but not yet a primary goal.
Yeah, so
Okay.
I think that's a very important question. And as are all these questions are excellent. I think we shouldn't focus, not with all due respect to Dr. Kralovic, we can't focus as clinicians responsible for patients on a single isolated abnormality, even though we know that it has a bad prognostic significance, such as ASXL1. We have that in a patient who is in otherwise complete remission with PV. By law, we have to point out that he has this molecular abnormality, but the patient is doing extremely well on interferon with a low JAK, and I don't know what that means, but we're not going to transplant him just because he has this molecular abnormality. Do you want to comment on that, Dr. Kalajian or Dr. Kralovic? I don't think one isolated abnormality makes the difference in caring for a patient. On the other hand, if you have a patient with myelofibrosis who has AXXL1 and IDH1 and 2, and he's 55 years old and has a match, I think that patient probably should be transplanted.
Maybe another question for Dr. Chen, starting with you, and maybe we will have comments after that. Is there a difference in efficacy between short-acting and long-acting interferons?
Coming from our chronic viral hepatitis treatment, actually, yes, they have head-to-head comparison using the short-acting interferon. This is every two day versus weekly interferon, and the study showing clear advantage of the viral clearance by using the weekly interferon. This has been done before.
And
yeah.
Is it due to, in my opinion, in my experience,
yes.
I believe that the better results we have on the long term in hematology with pegylated form is simply due to the better tolerance, so you can give the drug
right.
for a longer time,
right.
or is it a biological difference, or is it just
You're right. One is the better tolerance, the better compliance. The second is actually the blood interferon concentration is more stable and higher. I mean, average is higher than the 2 days, every 2 days injection. 2 days injection, you see many fluctuation, but the weekly you see a much better stable concentration. This probably makes the difference.
So JJ, the only prospective trial of interferons was in the chronic myeloid leukemia situation, where Schering Corporation ran a trial when they were making Intron A, comparing Intron A with a pegylated, they had a pegylated form of interferon B, pegylated B. And there was no difference in the results, and in fact, in a closed, randomized, blinded trial, the Intron A was better tolerated. So I think that's kind of amusing.
Okay, let's move on. How about this one? The treatment strategy of masked PV. Dr. Silver?
I pass.
You pass. Dr. Kalajian?
I don't recognize this entity because, as Dr. Silva knows, in France and in Paris in particular, we do red cell mass. And when you do the red cell mass, there's no longer masked PV because you unmask the PV and you can diagnose them as true PV, and then you apply the same strategy than for, let's say, what they call overt PV. So there's no difference in my opinion.
So that was an unrehearsed answer. I didn't ask Dr. Kalaja to answer that, but exactly, I would have answered it exactly the same way. I think there's more confusion that has been associated because of this term masked PV, because you can't define polycythemia on the basis of hemoglobin. It doesn't make sense.
Practically, if you have a case that has not too high red blood cell count, and by the new WHO criteria for diagnosis 2016 fits the criteria for PV, so it's unmasked, I like that, then you would treat the patient the same way as the regular polycythemia vera, with the same goal to maintain hematocrit low and everything else the same. So, all right.
Maybe a question for you, Serge, again about the scoring systems in myelofibrosis. There's a question about that. There have been, in the recent years, many scoring systems, and you can add letters before IPSS, and the last one shown this morning by Dr. Mesa is the MIPS. So what is your opinion about all these scores, and are they applicable to post-PV or post-PV-MF?
This is really important for everyday practice, and unfortunately the field of prognostication is not getting simpler. It's getting more complicated every year because everybody wants to publish their own experience, which is very good. I mean, we're going to publish probably our own experience, but that just brings a confusion to the field. And the well-established scoring system, IPSS, and then perhaps DIPSS or DIPSS Plus, are the ones that are widely used. Dr. Passamonti recently published a scoring system that has been validated by 2 other groups called MySEC-PM, which is the secondary to ET or PV myelofibrosis scoring system. We heard today about another experience. Unfortunately, I don't see that there will be uniform way anytime soon to address that. It's an evolving field. Not everybody even can test for all of these factors that are in some of these prognostic scoring systems. So in everyday practice, we do the best we can in given situation. Let's see.
I have a question for Dr. Kralovic.
Let's see another one. Will a long-term hydroxyurea therapy increase genetic mutation?
Well, there have been reports where long-term use of hydroxyurea has certainly been associated with it. Non-specific, by non-specific I mean a variety of chromosomal abnormalities. I'm not aware that, and those chromosomal abnormalities have regressed after the cessation of hydroxyurea. I'm not aware of any association with hydroxyurea with respect to any specific molecular abnormality developing with its use. I was going to ask Dr. Kralovic, why are the molecular abnormalities more common in primary myelofibrosis than polycythemia vera, which is not an indolent disease like ET? And certainly, indeed, patients who have higher phlebotomy requirements don't have more molecular abnormalities.
So I think we have the same idea, but I will let Robert comment.
So the question is why there is more mutation, where there are more mutations in myelofibrosis compared to other MPNs.
Well, more than PV with patients with active phlebotomy requirements.
So one of where there's no, I think hard explanation for it. I think I can only speculate that in myelofibrosis, the stem cell or the progenitor pool is displaced from its native environment because of the fibrosis. And a lot of the cells are in an suboptimal environment, right? It means that suboptimal environment, that access to cytokines is diluted because many of these cells float in the periphery or maybe go to the spleen, and the absence of the stroma that feeds these stem cells is one of the key elements of this hematopoietic displacement. And I think that such a displacement may trigger selection. Some mutations evolve that enable the survival under these cytokine-poor environments, and this could be one of the ways that perhaps influence the genetic evolution of these displaced cells. I mean, it is just a hypothesis. It's very hard to prove because it's like the question of the egg and the hen, which is coming first, right? So it is not a simple explanation for that.
Thank you. There's a question about treatment of ET, so I think it's interesting to go to this field for a few minutes. The question is, ruxolitinib was reported to be an immune suppressor used, for example, in the treatment of GVHD. What is your opinion about ruxolitinib on the one hand and interferon on the other hand for the treatment of ET?
Now, all the ET is very simple disease genetically and clinically and has excellent outcome. There is a small group of patients in ET that are not going to do well. They have uncontrolled signs and symptoms and possibly would have worse outcome. Maybe 10% of the patients, 1 in 10. And they would need something different than just hydroxyurea, and they would possibly like interferon. We use interferon in younger patients with ET. There are always young females in 30s and 40s that are diagnosed with ET that may need therapy, and I would use interferon. But in older population of the patients with ET, there are some that are overly symptomatic or have increase in the spleen or some increase in white cells. Not very often. And in this population of the patients, anagrelite, for example, as alternative would not really work very well. Cardiotoxicity is an issue as well. And in this population of the patients, ruxolitinib may be useful to improve the quality of life, control the signs and symptoms for the patients who are older and symptomatic. In the United States, there is a study underway for approval of ruxolitinib in a second-line setting for ET. This is for hydroxyurea-resistant intolerant patients, and the study is a phase 3 randomized study in a blinded way between anagrelite and ruxolitinib. And I hope that we're going to have a study with ropeg interferon very soon in the ET setting, which would be immune booster and biologically be more palatable to all of us rather than pills, and with the possibility of molecular responses on top of everything else.
Here's one. Is interferon. Here's one, sir. Interferon and MDS.
Okay, there is a question about utility of interferon in myelodysplastic syndrome with fibrosis. Would interferon work in MDS with secondary myelofibrosis?
I don't think so.
Why not?
Well, I think MDS is that there is a World Health Organization has a classification of MDS/MPN, and in our experience, those patients are too sick it takes too long for interferon to work really in patients who have such an acute disease. I don't know, JJ, have you used interferon in MDS with myelofibrosis?
No, no. I think when it was shown this morning for the several series in several countries that you have this subset of MDS with fibrosis, but we usually treat them as an MDS,
right,
without taking into account the presence of fibrosis in the bone marrow. So we use hypomethylating agents, etc., but not treatment for MDS is first and then. That's right. We do the same. So the next question. The next question is about the Proud Conti data. You see, the question is about the results are very promising. Do experts suggest PV patients to use ropeg rather than hydroxyurea immediately? So that's his frontline setting. So the PROUD PV study was performed mostly in untreated patients, although 1/3 of included patients previously received hydroxyurea. And I would say that if we look purely at the data of these trials, what we showed is that after 1 year, both drugs are equivalent. There's similar efficacy, but after 2 years, you saw the superiority of interferon over hydroxyurea in terms of maintaining the hematological response and increase in the rate of molecular response. So I would say that yes, based on these data, I would prefer to start with ROPEG interferon as first-line therapy and keep hydroxyurea as a second-line therapy.
I would agree.
I would agree.
Next question for Dr. Silver. For iron-deficient PV patients, is it necessary to have iron supplementation?
Well, that's an excellent question. So sometimes we see patients who are so symptomatic from iron deficiency that you are forced to do something to correct it. But you must always be aware that if you correct the iron deficiency by giving iron, that will make the polycythemia worse. That is to say, the phlebotomy requirements will go up. So we have used, we tend to use oral iron in those situations rather than giving intravenous iron, because if you give intravenous iron, as you know, it's in there and it'll take some time before that iron becomes utilized, whereas with the oral iron, it's a much slower absorption, and you can discontinue it if the patient feels better and the phlebotomy requirement goes up. But it's a very tricky balance, and the best way to avoid that is not to use phlebotomy only as a treatment so that patients become so iron deficient. That's why interferon is the treatment for early polycythemia vera in patients who have a modest phlebotomy requirement, which is about 6 to 7 phlebotomies per year. I want to say in defense of hydroxyurea, you know, that was a drug that was developed by the Polycythemia Vera study group. It's a very effective agent. No one's arguing that point. I think JG and Serge, you would agree. The issue is it has significant side effects. I believe the French data that it's leukemogenic, as Dr. Kalajian wrote in Blood some years ago. 3, it has no biological basis for its use, but it is an effective drug. Hydroxyurea was introduced by the Polycythemia Vera study group because chlorambucil, which is also very effective, an old oral alkylating agent, caused a substantial increase in the development of acute leukemia 5 years after it was first initiated in the treatment of patients with PV.
Thank you. So there's a question, I think it's an interesting topic also and practical problem in some patients about patients with primary myelofibrosis and CALR mutation. They respond usually to ruxolitinib in terms of spleen and symptoms, but anemia is still there. What is your strategy?
So there are several aspects here. So obviously the JAK inhibitors are not related to the presence of one or the other mutations in a patient. They work on the JAK-STAT pathway. And they are supposed to improve the quality of life, and the spleen can be reduced in many patients. It is not expected that anemia would get better. It is expected that there would be some suppression of the blood cell count. And in that case, I would look first at the erythropoietin level. If erythropoietin level is lower than 125, I would possibly combine with erythropoietin injections. If not, and many times it's not low, then I would add danazol or one of the testosterone-like medications or anabolic steroids in a way to try to improve the red blood cell count. And there are then studies that would combine lenalidomide or thalidomide or pomalidomide and also some novel agents with ruxolitinib in patients that are anemic. But it is a challenge. I try to keep the dose of ruxolitinib at the highest dose that is safe for the patients, because the highest dose usually relates to the best spleen response, and the best spleen response, the smaller the spleen gets, the longer the duration of the life of the patients with myelofibrosis that is on ruxolitinib. So it's a balancing act between the couple of factors here. It's a challenge. And
I have a question for that.
Sorry,
Yes.
can I interrupt and have a question here? Okay, thanks. Well, first of all, I think really the top-notch medical matters and science have been discussed they right here today. So I would like to congratulate all the outstanding speakers for the insightful and wonderful lectures. Now I have a question regarding making conclusions about the molecular response and the clinical response. So from what we heard today, that the mutations are very important for driving the disease progressions. And I think, so really, suppressing the mutation, suppressing the effect due to the mutations can be very important for the inhibition of the disease progression. So I would think that that's the fundamental aspects for the treatment. So my question is, are we supposed to be very selective in making our conclusions regarding whether there's a molecular response, the correlation between molecular response and clinical response? So it would be very difficult for me to imagine that a DNA damaging agent like hydroxyurea can cause a molecular response-based clinical response. So, but I think, so on the other hand, now we have data, now we saw the data from the Broward County study where there's a very nice correlation between the clinical response or the complete hematological response, including the durable freedom of phlebotomy with the molecular response, where for the complete hematological response, including the freedom of phlebotomy at about 70%, and the molecular response about 6 to 8%. To me, that's a nice example that we saw the real clinical effects. So I would like to from your panel. Thank you.
Thank you. I think it was an important comment, and as you mentioned, there's a nice correlation, but still we have to prove on the longer term that mutant allele reduction results in less transformation to fibrosis, less progression, and this is not clearly proven yet, but we have promising results, and I think everybody is convinced that eradicating the mutations is the first step to achieve these longer-term responses.
I have a question for our hepatology expert. So Dr. Verstovsek showed the liver function abnormalities in the PROUD study, and we've all observed liver function abnormalities with interferons. Are we doing the safe and careful clinical care if we allow the SGTT and go up about twice normal? Is that satisfactory to you? We've never really had a hepatologist expert tell us if we're doing the wrong thing or not.
Right. Yes, Dr. Silva asking about the gamma GT elevation noted in some about a certain case of the MPN patient receive interferon. We have said we found the same thing in the viral hepatitis patient. Some about 10 or 15%, they have gamma GT elevated, and even the AST ALT elevation. So and we actually did a liver biopsy for this patient, and the discovery most likely is due to the fatty change. So after, because in our case we just treated them for 48 weeks, so we can stop it. Stop it, then the gamma GT return to normal. So I think it's probably it must be related to something in the liver. And one possibility is the fatty change. Is the interferon induced the fatty change? Fatty change. So we need to pay attention to the long. If you continue use this interferon for a long time, we need to pay attention to the any hepatic effect in the liver.
Thank you very much. We still have many questions, and thanks to the audience for such an interesting session with many interesting questions, but we have to close the session now and move to the final session. Thank you very much.
Thank you.